How you doing, neighbors? Um, Today I'm gonna show you. Well, on this video, I'm gonna show you the difference on a stressed brain and distracted brain. So I'm gonna watch two videos. I'm gonna watch a video. For me, it's a big trigger to learn about FND or other conditions or whatever is related to that, or stress news, or things that they're stressing you out is a big trigger. And then I'm going to show you another video where I'm distracting my brain, and you will see the difference. See, just talking about it. Okay, so just watch.
So dystonia is defined as a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. The movements are typically patterned, twisting, and maybe tremulous, often initiated or worsened by voluntary action and associated with overflow muscle activation. And diagnosing dystonia typically utilizes a two-axis classification system. The first looking at the clinical features or phenomenology, and the second approaching potential etiologies. This new classification system is important for patients because it tries to encompass as many different clinical features and places an emphasis on putting together the clinical features with potential etiologies with the goal of improving diagnostic accuracy. Tremor is fairly common among patients with dystonia. It can be postural, that means occurring with changes in position of a limb, for example, or kinetic or action tremor, and occur in regions that are affected by the dystonia. Sometimes if the dystonia is very subtle, it can occur in the resting state where, for example, the limb is just stationary. It tends to be irregular in quality and can look like it's a little jerky in appearance. It worsens when you perform an action that moves the body part against the pull of the dystonia. And if you think of muscles that are pulling against each other, there's one dominant muscle group compared to the other. So when you put an arm, for example, against the pull of that dominant muscle group, there's going to be more tremor. And then when you put the arm, for example, towards the dominant muscle group, the tremor can lessen. And that's typically referred to as null point. Sensory tricks or any maneuvers that can alleviate the dystonia doesn't have to be antagonistic to the muscle contractions. It can be variable in nature and the duration of its effect. And the maneuver has a specific location to each individual patient. And there are different types of tricks. Visuals, just looking at something tactile. Cervical dystonia patients will wrap a scarf around their neck or hold their chin. Auditory, thermal. Task specificity is a loss of voluntary motor control during particular skilled tasks. And this can definitely play an important diagnostic clue in saying that a specific movement disorder is dystonia. Can occur in, for example, when someone is writing, playing an instrument, playing sports, and it likely arises after a period of repetitive or skilled movements in individuals who already have a functional or genetic predisposition. And all of these examples of skilled tasks really require a lot of precision control, more so than what our motor system has been evolutionarily designed to perform, resulting in the dystonic movements occurring during these skilled maneuvers. Here's some common forms of dystonia. These are common forms of cervical dystonia: forward pull or anterocollis, lateral tilt, retrocollis, and torticollis. This is a gentleman with isolated blepharospasm here. You see this patient posturing at the elbow, tight grip while he's writing. So that's commonly seen, for example, in writer's cramp. And this is someone with an isolated foot dystonia. So how do we approach someone who presents with these symptoms? So we look at their clinical features. How many body regions are affected? Is it one as an isolated blepharospasm? Is it half the body? Is the trunk and two or more body regions being affected as generalized dystonia? What is the temporal pattern? Is it progressive? progressively getting worse in nature? Is it specific to a certain action, such as writer's cramp? Does it start out fine in the morning and get worse throughout the day? Or does it occur in sort of spurts and supplemental episodes? And what are some of the associated features? Are there abnormal dysmorphic features, skin lesions, other movement disorders such as Parkinsonism? Are there balance problems associated with it? So all of that is very, very important. And then Axis 2 looks at potential etiologies. Now, when we're going through the evaluation of patients, it's important to ask about, especially young patients, birth history, developmental milestones. Older patients, we tend to ask about whether it's sudden in onset, so could it be from a stroke, for example, what medications they're taking. So there's several antipsychotic medications that can cause dystonia. About 20% of cases have a genetic etiology, so family history is really important. And then oftentimes we just don't find a cause. There are not really any specific diagnostic tests. Testing is guided by considering a syndromic approach. So we look at the clinical features, see what abnormalities are present, and based off of that can order specific imaging. So for example, if there are eye movement abnormalities, we should consider a neuro-ophthalmological evaluation. If there are focal neurological signs like changes in the reflexes, changes in the way they're walking, especially younger children who develop symptoms abruptly.
I swear to God, this hand dryer just turned on by itself. And that's how far, like, this is how far away I am from it. Turn on again if there's somebody here with me. I myself, right? I'm not even wiping my.
Okay, neighbors. So I'm finished watching the video. That it relaxed me. I'm more calm than when you saw me shaking. As you can see, when my hand starts throwing punches or my legs, I can get hurt pretty bad. I hit myself all the time because it hits towards me or it hits out to something or someone, and that's not good. Same with the kicking. I have kicked the car so many times and I hurt myself. So when I hold, like you saw that I try to hold my arm towards me so it doesn't punch, then it triggers other parts of the body. Like you saw my whole body shaking side to side. I don't know why it does that, but it can be tame. It can be tame. It has to express how it feels. So that's what happens. It figures out a way in another part of your body to keep doing what it's supposed to be doing. And I guess it's the shakes, the tremors, the ticks, or the spasms. But it does it. It has to keep doing it until it stops. And like I said, for me, that I noticed that it helps me calm down is by watching something relaxing, something funny, especially. That's how I calm down. But this is what we go through, and I hope this video help you. And I know a lot of people go through these same things, and this is part of our lives. We deal with this all day, every day, and it amps, like it turns the volume up and it lowers the volume. That's how the brain is doing to us. It when it wants to keep being loud, it does it, and when it wants to be quiet, it's quiet. But thank you again, neighbors, for coming over, and vecinos también cuídense mucho. Y los espero otra vez en el siguiente video. I will see you again in the next video. I kind of forgot what I was saying. Adios.